me to just go through what I've got written down?
Yeah.
So I thought your introduction was very good. You introduced yourself, you got the patient's name, date of birth, so you got the right identity, you checked their preferred name. You started with 2 open questions. So we normally, over the course, you must have heard, at least for myself, I normally like to ask 3 open questions or 2 open questions if I'm happy with enough information. So I think that was a good start. As you say, you displayed empathy. You said things like that must be quite distressing. That must be quite difficult. So those were really good. Initially, I think you were slightly muddled because you thought it was both arms, and you clarified that very early on. And this is where clarification really helps. So feeding back to the patient what you've understood on a regular basis means if you've not got anything right, they will correct you so you can then move back to the right path. So that was well done. The patient gave you 1 cue in that whole scenario, which was this has happened before. And you picked up on that cue straight away. So that was really well done, because that gave you an idea that this has happened before, which changes the scenario. It was an excellent question about eyesight specifically. I thought that was a very good question because that was one of the hidden things in the scenario. And actually what that was amaurosis fugax, basically. I don't know if you've heard of amaurosis fugax. It's a form of TIA, right? Exactly. So that's what that was. And then you clarified that the symptoms had gone away completely, so you made sure it wasn't a stroke. Patient asked about MS early on. You didn't commit, which is good. In our videos, we talk about sort of managing that need for a diagnosis early. You went through the patient's ICE relatively well. You managed ideas, concerns. You didn't have time to go through expectations. But I feel Dr. Ahmed was a difficult patient in some regards, because sometimes we do this on purpose. We talk a lot because sometimes the patients will be very talkative and they won't be quiet for you to get through your thing. So you need to develop ways on how to bring someone back to the path that you're on a little bit. If you think it's not a cue, then you need to have a way to sort of move things along a little bit. Yeah. You went through systems review, you did all the past medical history, drug history, social history, etc. And management, you're right, you could have got there. I think you could have got there about a minute earlier. And sorry, I had COVID recently, that's why I'm coughing. So basically, what the statement was the main differential here was a TIA.
Okay.
All right, so what you'd be doing there is you'd be saying, right, I'm going to refer you to the TIA clinic and refer you to see a specialist. In the meantime, if these symptoms happen again within the next few days, you need to come back, because that's a red flag. If a patient has more than 1 TIA in 7 days, then that's, I believe the term is crescendo TIA, in which case they need to be admitted because they're extremely high risk of a stroke within the next few days. And apart from that, you could give them aspirin 300 milligrams stat dose. One thing I'd say on examination, you asked about heart rate, blood pressure, and then you said systems exam. What I'd say is always clarify what examination you require. So say, can I please have a cardiovascular exam, or respiratory exam findings, and a full neurological examination finding? And that's why I only gave you cardiorespiratory findings, because you could then say, could I also have a full neuro examination? Because what you're doing is you're displaying safety, right? Because you're asking, you can never ask for too much information, but you can ask for not enough.
Yeah.
Does that help? Does that make sense?
Yeah, that makes sense, yeah.
Good. That was a very quick review, because this is a short webinar.
I think with regards to this station in particular, again, there was some cues within the station as well. One thing was the cholesterol and the family history. So the cholesterol was massively elevated at 10, and the fact that her brother died very young, under 50, as did the dad, and she smokes, and her cholesterol is double where we want it to be. So you must be thinking potentially that this might be kind of some sort of familial hypercholesterolemia. There's obviously some sort of cardiovascular disease within the family that runs within the family, and it's good that you got that family history out there as well, or you inquired about family history. And I think that's again puts you more at put this patient more at risk of something cardiovascular. This is more in keeping with a TIA rather than MS. Now, obviously, we know that MS presents in lots of different ways, but I think the fact that this is a recurrent and like amaurosis fugax, I think that's almost an indicator. Actually, it's quite indicative of a transient ischemic attack. So yeah, I mean, for those of you who've joined us, hello. But we were just going through the station, practice station, and it was a TIA station. And if you haven't learned about TIAs, obviously learn them, strokes, and how to manage those. It's really quick and easy to learn, and it's something that's really important. That as you all of you doctors, imagine once you start working within the NHS and you work within acute medicine, at some stage you're going to come across someone that has a TIA. So you need to know how to manage that.
And on the whole, I just say, really honestly, well done, Salman, because you did this in front of 2 GPs, 2 other highly esteemed members of TrewLink Academy, and your peers. So it's no easy task to do that in front of people. So the fact that you managed that well in this sort of pressure, in this sort of setting, is a good thing. So I don't want you to be disheartened. I think you did quite well.